Welcome back, everybody, to another episode of You Make Me Sick. Michaela, you with us?
I'm here, Andy. How are you?
Wonderful, wonderful co-host, Michaela. Today, we're joined by a very special guest, David Ibbitson. David is a registered nurse at Boston Medical Center. He is on a rapid response team. For those who don't actually work in hospitals, the rapid response team is a specialized group of nurses who respond to situations that begin to escalate within units who aren't really prepared to handle that level of care. So today, Dave is with us to kind of explain exactly what a rapid response nurse is, their role in the hospital, kind of some of the history behind how long he's been doing it, and just kind of explain to people how important the role is. So Dave, thanks for joining us.
Yeah, thank you for having me.
We're happy to have you here today.
So the term rapid response nurse, people who work in hospitals are pretty familiar with it, especially all trauma centers have them. Most hospitals now have a team in place for a rapid response team. But I was wondering if you could kind of explain what your role is as a rapid response nurse.
Yeah, as you're alluding to, it does exist in a lot of hospitals, and it kind of varies from facility to facility what the role is. So in some places, it's just an indirect charge nurse from the ICU that will come out and respond to, a rapid response on the floors. Sometimes they're even considered like the indirect charge on the floor. That is a kind of like a resource for the staff on that floor. At our hospital, it's we don't have a patient assignment, and we just kind of will roam the hospital. We have kind of our watching list that we'll keep an eye on certain people that we're concerned about. And the goal is to hopefully decrease the number of rapid responses, especially the number of code blues on the outside of the ICU. But yeah, we just kind of get free range on triaging patients as we come across them.
Okay. How many people are on your team, Dave, where you work?
Yeah, so there are two of us on each shift, day and night, so a total of 11 nurses, but we cover 24 hours a day.
And you guys are responding to, all sorts of situations, but essentially if it's on a unit that in the ICUs, they're kind of prepared to handle, respiratory issues or cardiac arrests. Other units, even though some of the staff may be trained on how to respond to that, they don't usually have the resources to handle that. So as a rapid response nurse, did you have ICU training, or do you have to have ICU training? What level of experience do you need to actually become a rapid response nurse?
Yeah, so the main criteria is that you have to have 5 years of ICU experience in your background. You can also have ED. You could have experience anywhere else. Ironically, it's a lot more similar to like a paramedic, because you're kind of walking into a situation with minimal knowledge of what's going on. You're just trying to triage it based off of what you're seeing, and then figuring out what we need to do to get the patient to where they need to go. A lot of times the patient can stay right where they are during a rapid response, but sometimes they do need to escalate to a higher level of care. Or you might walk in and it might actually be a code blue, just not activated yet. So.
And what was your background going into this role for you, Dave?
Yeah, so I started at Boston Medical as a med-surg floor nurse. So I did med-surg nursing for about 8 years, and then I did ICU float for 5 years, and then I've been doing this for probably the last 6 or 7 years.
Do you think as a float nurse, that experience because our float nurses float to all the different ICUs, so you see all the different specialties, the neuro, cardiac, medical, all that stuff. How much do you think that has actually helped you with regard to being a rapid response nurse, where you have no idea if you're going to show up to somebody who's in, respiratory distress or having a cardiac issue or some kind of possible neurological issue?
Yes, I think that gave me a very strong foundation on, knowing what I could build off of what I knew. And then going to the ICU, it let me have developed those critical care skills that I was able to enhance my knowledge on what the patients needed in the moment. I think more importantly, though, I think the floor nurses, sometimes they just feel like they don't have a voice. Like they'll page the providers, and the providers, to be fair, are very busy. Their lists get longer, and discharges get more complicated, and sometimes they're not allowed to, they can't afford to give them the attention that they're asking for. So sometimes I can assist that nurse in, being heard with more urgency,
So you had mentioned it's kind of like being a paramedic, and paramedics often, they work kind of independently, sometimes in pairs with a paramedic and an EMT or two paramedics together. Do you ever have backup? Like, how much help do you have on any given day? Is it just you by yourself? Do you have multiple rapid response nurses?
Yeah, so there's always two of us, and the way that we usually handle it is we go about our rounds independently, and then if there's any emergencies that are called on the overhead, such as like a rapid response or proceed out or a code stroke, we both will make it a priority to get there, because sometimes it is helpful to have another set of hands in that situation.
You said you had acted as like a resource for, med surg nurses who maybe don't get as much support from the physicians at the bedside. Do you feel like when you reach out to the teams as you kind of stepped in and assisted that they are more receptive to what you have to say? Or
Yeah, so we do have a pretty good working relationship with the both surgical and medicine residents. Usually, one of my colleagues, Katie, will meet with them each time that they start up. So she kind of clues them into our role, and at a very early, part in their career, they realize that we're here to help. We're here to help them triage situations and to sometimes it's difficult for a new resident or intern to realize when a patient is really sick. It's not like they have a flashing sign saying that I'm sick above their head. Sometimes it's more subtle, and you might not appreciate it until you've seen it a couple of times. That's what medicine really is. It's more, learning from your experience. And as a new nurse or a new doctor, you might only have 1 year of practical experience, whereas if you call a rapid, you might have 40 or 50 years of nursing experience showing up at the bedside, which can help a lot.
right. Yeah, nurses often develop that like sixth sense. So when a patient's like deteriorating, like you kind of know it's coming. So has that intuition kind of helped you like identify higher risk patients that you kind of need to respond to that you
Yeah,
may
I
know
think
that are deteriorating?
yeah, it does. It definitely does. Because you see so much over time. You can be book smart, but it's also a lot more the practical, being able to recognize things, on an individual basis. And maybe if the nurse has taken care of the patient, consecutive days, they can tell you they look a lot worse. I put a lot of, impetus on that data point. If they tell me they looked a lot better the day before, then that tells me, even though the labs might not support that they're getting worse, that clinical gestalt, even as a young nurse, you might be able to sway my, tip the needle one way or the other.
Yeah. Yeah, I mean, the nurses are the ones at the bedside for, all day with the patients. So, you're having conversations, you're talking to them, you kind of know when something's off.
Hmm. Definitely.
Those red flags start to show.
Definitely.
Do you, just out of curiosity, so you kind of manage essentially everything out of the ICUs in the ED? Like, do you cover the ED at all, or is that? I mean, that's primarily handled in the ED, right? Or do you ever
Yeah,
go
but
there?
we do. So there's a lot of things that we're required to show up to. Any overhead. So proceed out is a non-bedded person, so that could be staff or a visitor. If they look very ill, anybody can call a proceed out, from a housekeeper to a nurse manager. The goal of the proceed out is just to whisk them away to the ED, but that could be called in. You know, there are 5 different buildings that are all attached, so it's a large footprint, and it can be called any spot in the hospital. And some of those areas are responded to by the ED, but we're also expected to go as backup, because if they are understaffed and they have 3 trauma rooms going, they might not be able to send anybody. So there's been plenty of times that I've gone to one of their areas and been the only responder. We also have to go down to the ED for like a sick, they call it a P1 or a priority 1. So if somebody's, stabbed or shot or been in an accident with like likely an arterial injury, or, something that is very, life threatening, then we're supposed to show up to that. And it's usually just to give extra help, just a all hands on deck kind of approach. But ironically, usually when I show up to those, I find myself helping in a different room. So like all the people are in the P1 room, but there might be a newer nurse by themselves in with a, medical mystery case that's been going on for 2 hours that the other staff have kind of abandoned. So sometimes I'm helping out in other areas down there, and we also have to show up to any code strokes in the ED, which aren't overhead, so you don't hear them in the hospital. But a lot of times there's a code stroke in the ED because if you think about it, they have to code stroke anything that's suspicious. And it can be a lot, especially when you're just meeting a patient for the first time. And also anybody that comes in with a possible MI or anybody that needs to go to the cath lab for a pericardial effusion or an MI. Usually we're required to show up to them, those patients.
So you don't just respond to patients who are in the hospital as patients. It could be absolutely anybody. And like you were saying, there's 5 different buildings because the Boston Medical Center campus has all their clinics there too. So you have your ENT and, this all these various different specialties. So if you had a rapid response for somebody who's in the GI clinic, you'd have to go to that and see them too, right?
Correct. Yeah.
So you're responsible for just probably hundreds of patients throughout the day, correct?
Yeah. So usually we divide up the list. So as about 250 patients on each person's given assignment. We divide up the hospital into half, and then we'll give sign out to each other. There'll be ideally 10 or less patients that we're actually like acutely watching, but sometimes it can go up to 20 if they're more of just like a FYI, like this person's getting this therapy that could cause a reaction. It's good to know about them and in handoff. So when we give handoff to each other, we'll pass on our shorter list of watchers.
And then, so do you feel like you just make rounds throughout your shift, kind of just checking in on those patients, assisting when needed?
Yeah. So I think part of it is if you call an emergency and you haven't really met me or talked to me that much, when I show up, you'll just be like, oh, who's this guy? But part of it is just a network. So when I go through L&D or mother baby, because that's also areas that we round, a lot of times they don't have any direct needs. Like when they do, usually it's pretty urgent, but I want them to feel comfortable reaching out to me. So on the day shift, we try to round to all the units like every 4 hours. And part of that is not just talking to the charge nurse, it's kind of networking with all the newer nurses. And I've had to adapt over time also because, to kindly word it to myself, I guess, the age gap has changed quite a bit. So, I'm trying to connect with, a generation that might not see me as, as warm and bubbly as they would like. So I'll just ask them, do you have anything, interesting that you haven't seen before today? And that engages them more instead of just saying, are you doing good today? Then they'll just be afraid to say that they're not doing good because,
right.
So, but then I might find, they've never had a trach before and they don't know how to suction the trach. And then I can walk them through that. So there's a lot of education that goes along with the role that I like to think helps to prevent a emergency from happening if the proper care isn't being delivered because we're just unsure how to do so.
Those relationships that you build, like it seems like it's been pretty easy for you to, just kind of gain the trust, I guess, of the different units and where you're at. Do you find that you ever, I think Michaela kind of asked this earlier, you ever get any kind of, pushback when trying to transfer a patient, or if you have a patient who, may not, one unit may not deem appropriate? Are you kind of the last call on that as far as like, look, this patient needs to come here right now. You guys have to take them. Have you ever had any kind of issues when trying to transfer somebody who's kind of on the edge of possibly coding?
Yeah, I mean, there is this misconception that we have more power or authority than we do. We're, a lot of nurses when they join, like my team, they're taking a pay cut. We don't get any differentials. We just go around and we just help out. We have no actual power as far as moving a patient. We can weigh in with our 2 cents, and we do have working relationships with a lot of the attendings that cover the ICUs and the and in the ED as well, just because we're showing up to all these things. So they might like heed our call a little bit more than an intern that they just met the first day of their rotation. But that being said, we're just trying to put our 2 cents in, and we all just want what's best for the patient. So
Yeah. Dave, can you kind of walk us through a situation where maybe a rapid response is called? What do you do and what's your role in that rapid response?
yeah, so a lot of times when you're coming to a rapid response, especially if you don't know the patient, you're just trying to, within the first like 10 or 15 seconds, you're, in my mind, I'm saying sick or not sick. Like, is this something I need to resolve in the next like couple minutes, or do I have a little bit of time to figure this out? And then once you figure that out, and if it's the first of those options, then usually you're probably escalating it to a code level. It might just be because they have to get intubated, or if nobody actually has a pulse when you show up, which happens unfortunately, then you just start CPR and call the code. But fortunately, most of the time that's not the scenario. A lot of times you're trying to help to gather the information you need to see where the best location is. There was a good example recently where the rapid actually lasted for a solid 3 hours until we figured it out. So that's, it took a lot longer, but it was also important for the patient because we had to make sure we were delivering to the right ICU, honestly, because when I showed up, the patient was unresponsive. At first they checked the blood sugar and it was low. They thought that was the problem. And if it was, perfect. It would have been fixed in 5 minutes. Great. But that wasn't totally the problem. The nurse said she looked a lot worse. The plan was to dialyze her and move her to step down and do HD on her, but it still didn't quite sit right. So the lab showed a low hemoglobin. We were worried she could have a GI bleed and the lactate was elevated. So we brought her down for a CT. That actually showed a pericardial effusion, which was new. So if we had stuck with the first plan and brought her to step down and dialyzed her, she probably would have had a cardiac event because she wouldn't have been able to handle that much of a fluid shift. And then cardiology came to the bedside, didn't echo. Ultimately, we settled on going to the MICU. But in that 3 hours, we had the SICU, we had the CCU, and we had the MICU all consulting on the same person. And that's how we safely navigated her to where she needed to go. And I had to communicate that with my other colleague because I had to make sure that they knew not to commit to anything. Because I was like, I am with this patient for the next until we figure out where she's going. So if we both commit to something, then neither of us can show up to the next emergency. So it's really good to work in, good communication with your colleague.
How hard is it in those situations? So, Michaela and I, also when you worked in the ICU, it's, even though it's, can be hectic and chaotic, it's still pretty controlled. You have monitors, you have the support that you need, you have the drugs that you need. How much of that control do you lose as a rapid response nurse when you show up to a situation and, you're kind of maybe walking into it, not necessarily blindly, but with very little information? Do you feel like that loss of control changes how you assess situations?
So I think one of the most important personality traits that you can have in this role is to bring calmness to a situation. So if you walk into a situation, personally, what I do, I don't share it with a lot of people, but when I'm walking to a situation, I try to do a little bit of rectangle breathing or box breathing, whatever you want to call it. I try to slow myself down before I come in because I don't want myself to get all worked up just by running to the situation. So I try to bring myself down a little bit as I'm arriving to it. And it does help personally to come into it with a calm, that simple breathing method just helps to calm me down, activate the parasympathetic system, and just make me more effective in a situation. And you might have less resources in the ICU sense of the word, but you have a lot of hands on deck and you have a lot of people that are intelligent. You just have to know what their strengths are and to delegate tasks to them that are appropriate for them to do, so you just have to use what you do have available. Usually you have everything you need in that room. So it's more just knowing that goes back to rounding and getting to know all the people on the floors. Once you know what somebody's strength is, you can use them to their best strength during a situation.
What do you usually have on you in terms of supplies or medications to go into these situations for patients?
Well, it's funny because prior to COVID, we didn't really carry anything with us. We just kind of walked around without anything. And then, it's evolved over time. We started to carry a little fanny pack or a backpack type thing around with it. And, each one of us carries different, accoutrement of different things that we decide that we need. I tend to go a little overboard, my colleagues will say, but it's all stuff that I found is difficult to obtain, or it takes a little while to obtain during an emergency.
You should never be too prepared.
Yeah, that's what I like to think too. But sometimes my back or my hip will tell me otherwise. So I am trying to be a little more mindful of what I should be carrying around. But yeah, so it's each person carries around a lot of different pieces of equipment, but we pretty much all of us do carry around a handful of items that we find the most important to have with us.
Do you guys need standard just kind of procedure, at least in the ICUs, you typically need a physician's order, anything that's out of the scope of nursing practice to administer for medications or interventions. Do you guys need physician's orders if you have an emergent situation to actually provide kind of life-saving care? Or does that fall under the scope of almost like like ACLS guidelines or
Yeah,
ELS?
I think there's some things that you would be covered on. Like if you walked in, like we're ACLS certified, so like anybody that's ACLS certified can run through the algorithms. You're trained on that. You're certified to do that. In a hospital setting, you hopefully will have a doctor there, a resident there that's going to be your team leader. But if you come to a situation that they're not present in, then you can run the code until they arrive. That being said, we don't have any protocols for if I'm going to walk into a situation and want to get a certain test, like a X-ray or a CAT scan, or to get certain labs. We don't have any preset orders that are designed for us to be able to do that. But often I will page the providers and say, hey, I think like I'd like to draw an ABG on this person. Can you come to the bedside? And they're usually on board with that. They'll show up pretty quickly if they know that we're that concerned about the patient.
Yeah. And so do you find that it's more difficult to perform some of these life-saving interventions that you do if you were to respond to something that was outside of one of the nursing units where you can kind of have more access to supplies and medications?
Yeah, so that's that's really ultimately why we do carry around our supplies. Is we've had codes in the eye clinic, we've had codes, in like waiting rooms or in bathrooms where there are no supplies. So you do have to be mindful. It goes back to that old nursing school adage: make sure you're safe before you go into the room. So if there's somebody down in the bathroom, you're not just going to jump on the floor in the stall next to them. You got to make sure that everything's okay in the room. Otherwise you'll end up getting stuck by a needle or getting covered in vomit or something like that. So, but yeah, once you make sure that the room is safe for you to go into, then you'll start using your supplies to make sure they're safe. And that's also why the part of the proceed out team, it's the resource nurse and the medicine consult resident, or at night it's the third year resident, the senior on for medicine. That's part of the proceed out team. So that way, if it turns into a code, you have like a very small code team that's built in with, a nurse and a doctor.
Yeah. And for our listeners who are not sure about what a proceed out is, it's a situation where maybe a family member or someone who's visiting a patient in the hospital has a medical emergency that needs attention. And so our resource team comes along with one of the physicians, and they kind of together assist the patient and bring them to the ED where they can get treatment.
Correct.
So you've been doing this for a while. In the years that you've been doing it, have you ever shown up to a situation where you were just like completely shocked at what you saw? Or have you kind of been desensitized to a lot of kind of, what the possibilities could be?
I wouldn't say desensitized. I do have certain things that throw me off my game, so to speak, but then I try to center myself as quickly as I can. But a lot of times if there's a child or a baby being born, that does throw me off a little bit. But then you gotta, we still have to respond. We still have to, be one of the people that are trying to think clearly. So, we've had babies born in the driveway. We've had them born in the lobby. Like I've gone down to pediatric events and had to put an IO in somebody's, a baby's leg because the team had already missed. That made me hesitate a little bit. So because they see me and they're like, "Oh, you can do this," and I said, "Yes."
Dave's really breathing in that box.
Yeah. I was really, really struggling to keep centered there, but but part of it, like I said, is just trying to stay calm.
Yeah, I feel like for a lot of nurses too, Dave, kind of having you come into those situations, they then feel calm because they're like, "Oh, Dave's here."
I do hear that a lot,
It takes that pressure off of them and kind of puts it on your hands.
like a therapy creature.
Yes.
Even in my own experience as a patient, it was very nice to see Dave show up when I was lying in the hospital bed. It was like, familiar face. Somebody who actually knows what he's doing if I need something. So
Honestly, that is a good example of something that threw me off. When I went down and saw you in the trauma room, I was just like, "Oh, okay, all right," So, but I was, part of the making sure you moved through to make sure you got everything you needed in a timely fashion.
which I appreciated and still do to this day.
Yes.
Have you ever shown up to a rapid response and just found the patient had already expired and nobody was doing compressions, or there was no interventions being done on somebody who had already whose heart had already stopped?
Definitely. And that's okay. I think the important thing is so in the moment, you still want to stay calm. Like usually when I'm showing up to those, I'll say, "Do they have a pulse?" They often don't look like they have a pulse. And then if not, then I say start CPR, and then I'll start to help kind of guide the room as we're going. I do find it's trickier because in this role, you can't, if I jump on the chest and start doing the CPR myself, then I'm not as effective as delegating that to somebody else, because almost anybody in that room should be able to provide BLS compressions, but I might be better served at helping to make sure that somebody's on airway, that we have IV access and getting the code card and kind of delegating those tasks out. So it's tricky because you want to jump in and do things, but you have to realize that it's more important to delegate. And we've also had codes called for people that rigor mortis had already set in. Just recently we had to put an IO in, and they paralyzed the patient, and anesthesia couldn't move the jaw. So I don't know if you guys are familiar, but that means that rigor mortis probably had set in about 2 hours to 3 hours prior. Because
and it takes hours for rigor mortis to actually set in. So
right.
So the patient, had they just passed in their sleep? Is that what
I was probably after lunch at some point. This was, at 5 o'clock or so. But we have the smaller muscles in your face. It's like about 2 to 3 hours. Then your larger muscles, it's more like 6+ hours. So it's like they weren't stiff on their whole body. It was just their face and their mouth. Anesthesia couldn't move their jaw even with the paralytics. So yeah. So I mean, we've had that happen too. But
when you feel like you're like delegating the roles that you like, someone's on compression, someone's on medication, someone's on the pulse, do you feel like since your role is pretty independent when you show up to the room, that building those relationships that you have with the RNs by doing your rounds throughout your shift, that you find it easier knowing like what skills some staff have and their knowledge and their experiences to kind of
and sometimes even with knowing people, they you don't know how they're going to respond to a situation. So like I like to say this, we learn the fight and flight, right? Fight or flight, but there's also function and freeze. Like there's all the F's I feel like that you can get. So some people will just freeze, some people will run away, some people will actually function a lot better. And I feel like a lot of the people in critical care and emergency medicine, they have that type of an F when they're coming to a situation. They function, they run towards the flames, and they're trying to function at a higher level. They're using that surge to better themselves and to better their thinking. Like, they definitely are able to channel that in a productive way. But also another thing that I want to make sure we touch on is after a scenario, especially these ones where you come in and the patient's already expired, it's important to do a debrief during rapids, during codes, during pretty much everything. I find it very helpful to the staff, nurses at the bedside, to make sure I circle back and talk about, how they're feeling, how it went. A lot of times it's their first time calling a rapid or their first code. And it can be challenging. I feel like when I first started the role, I wasn't as as thoughtful at going back to making sure that that they were doing okay. We see a lot of stressors in the field, so it's important to make sure everybody's okay to come back to work the next day.
Do you ever feel kind of overwhelmed in the role? Do you feel like you guys maybe there are certain days where you could use more help, or just overall, it would be helpful to have more rapid response nurses?
I, um, I think it's a loaded question because I think definitely there are some days that we could. There's some days that we go around, we're able to round, and we're able to keep up with all the workload. I think the more important thing is trying to make sure that when people reach out to us, they're giving us the appropriate data points that we can use to triage that. So we might get 10 pages in like a 1 hour period, or 10 texts, in a 1 hour period. If they tell us the right information, we're able to triage that and see the patients in the appropriate time frame. But for instance, like if a nurse just says, I need a new IV, that's going to go to the bottom of my 10 pages. But if they say, I need a new IV because the blood pressure is 70/40 and the blood infiltrated when they're getting it, then it's obviously going to go to number 1. But, or if they page for a VBG, if a provider pages us, because on the floors, the phlebotomists don't do the venous blood gases. So it does add a little bit to our plate. Anytime they want a venous blood gas, it always comes to us to get it. If they tell us like it's because the bicarb is 4 on the chemistry, then I'm going to make that a priority. But if it's just, I need a VBG because they were admitted 5 days ago for DKA and I want to see if it's better, that's not really, as concerning to me. So, but yeah, so I think it's a lot of, as long as we're able to get the appropriate information, I think we do pretty good with what we have. And we are doing I'm working with one of the educators for 4 West, and we're doing what's called a clinical insight program, where the new grad or a nurse with less than 2 years experience, either at the end of the orientation or at the end of the 2-year period, will go with, they'll do some simulation stuff. And then they also follow me around for 4 hours, or at night, they'll follow Katie around for 4 hours. And the goal is to try to, help them, number one, to feel more comfortable reaching out to us, but also to advance their critical thinking, so that way they can give us the appropriate information when somebody's not doing well.
Yeah, kind of seeing like what your expectations are and kind of how they can best suit you guys and what your needs are to show up to a response and be effective.
Yeah, and honestly too, some of it is they think, our role is that we're running from one emergency to the next emergency, which really isn't the case. So if we're doing our job well, we're, negating that whole emergency from happening. As long as we know about it and we're trying to stop it from being an overhead. Like I hate when I hear a nurse say like, "Oh, I didn't want to bother you with this." It's like, "Oh, just text it to me and let me know about it. That way I can let you know if I have time to help you with it or not." So.
If you could change 1 or 2 things about your role, what do you think they would be?
Hmm. I think that would probably be like one of the big ones, is just to make sure that staff is aware that we're there to help. It's not always going to be something life-saving. It could just be, you need an extra set of hands for, or you need some education around, a chest tube, or something that is foreign to you, like a pericardial drain, something like that, and I think they are doing better at reaching out. So I think it's, rounding and getting to know everybody is definitely paying off. But yeah, I think I just want them to know to feel comfortable to reach out, and you'll get different responses from each person. Each one of us handles situations differently. So, just because maybe you didn't get a response you wanted one time, try again. Just see and it could have been that we were too busy to help with that task that day, and we have more time this day, so.
With regard to kind of specialized care in the different ICUs, do you need to have competency on just the different types of interventions that are applied, like say, like a balloon pump in the CCU, or even something like CRRT that all the units do, or ventricular drains in neurocritical care? Are those things you have to be completely familiar with? And I'm sure being a float nurse, you probably saw a lot of those anyway, but do you get education on those interventions just in case you need help with a patient who may have one of those?
So I think it's a good question though, because it plays to each one of us has different strengths. Like for instance, one of our nurses spent 8 years in the CCU. She is probably the smartest cardiac nurse in the group. So I could send her a picture of an EKG that I'm questioning, and she would be my best source in my group as far as like, answering that question. Some people have more SICU background, so they're a lot better with that type of patient. But ultimately, the role of resource isn't because we know everything. Like nobody can know everything, and frankly, you shouldn't trust somebody if they seem like they know everything. That's not going to be a reliable source for you because nobody can possibly know everything. Our role is more, if you ask us a question, if we don't know the answer, we will go to somebody that we trust that hopefully will know the answer, and we'll be able to communicate it back to you.
Kind of acting as that liaison.
Yeah. Yeah.
What advice would you have for nurses who are listening who one day may want to become a rapid response nurse if they feel like that's kind of the path that they want to take? What could you tell them just in their journey to become a rapid response nurse?
Yeah, I think definitely get involved with critical care. You need if it's at our hospital, it's 5 years experience, but just know what the rapid response nurse requirements are at whatever facility you're at. I would definitely want you to be comfortable with being a preceptor, a mentor, because a lot of this is that role. Like you're doing a lot of teaching. You want to make sure that people feel comfortable reaching out to you with questions, and that anything. When I take a lot of nursing students with me. We have a lot of clinical groups on the floors, and I love it because they'll ask these questions that I've kind of forgotten to ask. And it will make me think about things that I haven't really thought about necessarily. So it kind of pushes me to become stronger as a nurse. But yeah, so definitely try to do that type of precepting, mentoring, and get that critical care experience under your belt.
Excellent. Before we leave, one question for you. So healthcare providers, we usually watch healthcare related television shows, whether it be documentaries or, just the fictional stuff that's out there. Do you ever watch any medical based TV shows? And if you do you have a favorite?
Yeah, I've watched my fair share. I would probably, the one that I'm watching recently, which is kind of not totally medical, but it does have, an overlap, is Shrinking on Apple TV. It's a comedy. It has Harrison Ford and Jason, was it Segel? I don't remember his name. The guy from Forgetting Sarah Marshall and that stuff.
I think so, yeah.
Yeah. But it's, so there's psychiatrists, and it's just kind of their life, kind of, going through their life, and, how each one kind of can unravel a little bit and they help each other out. But it does have some medical context. Harrison Ford has, has Parkinson's, and my mom has Parkinson's also. So it's, it's kind of interesting to see how they're taking that on,
Yeah.
Do
you have a show?
What's that?
Oh, I was going to ask Andy what his show is.
Yeah.
I was always a big fan of Scrubs, like the original. So they rebooted Scrubs, and it's been borderline disappointing. So it still has, the main cast members are there, but the main cast members weren't the best part of the original show. The ancillary cast were the best part of the original show. And none of the ancillary cast, or I shouldn't say none, but the best ones aren't back. The janitor, not there.
He was in Shrinking. He had actually, like, there's a bunch of, Shrinking reminds me a lot of Scrubs with its fast, witty deliveries and like stuff like, so the janitor guy's in it. The nurse, the girl that was in it from the beginning, she's in it too. She's the mom in Shrinking.
I wonder if, who was it? I'm trying to think of the guy who, Bill Lawrence is the guy who came up with Scrubs. I wonder if he's involved in Shrinking too.
I think he is, actually. I'm pretty sure. Yeah. Yeah, I think you'd enjoy it. If you have Apple TV, or it could be worth doing a free week subscription just to binge,
I'll have to check it out. What about you, Michaela?
I am a Grey's Anatomy lover through and through. I will keep watching as long as they keep going.
Yeah, I never watched that, so I'm not like a big drama. I remember when I was younger growing up, ER was like the show, and I watched the first few seasons of that, and then stuff that comes out now, I have a hard time because we live it, it's reality, and these shows a lot of times just don't really portray it. I love House, but in House, it's like, oh, the physicians are the one drawing the blood and doing the test, and it's all the things that are just it's not reality. I had a patient a few months ago, I'd been in there half the day with him, turning him, drawing his blood, doing all these things, telling him, what his labs look like. He asked me how come I was doing all the work. I was like, who did you expect to do all the work? I was like, God bless our physicians, but you might see them for 15 minutes a day. So,
Yeah.
Yeah.
but anyway, yeah. So I have a hard time with like my wife is into The Pit, which is on right. I guess it's a
That is
pretty
great too.
popular one right now.
It's
Guys,
crazy. Yeah.
I can't do it. Like I live this. I don't want to sit down and watch hours of it each day. So I don't know. I'd rather watch baseball.
Right around the corner.
Yeah, right. So, well, Dave, thanks for coming on. Do you have any last thoughts? Anything else that you'd like to tell us just about your role as a rapid response nurse, or just in general, for anybody listening who might be interested in nursing or healthcare?
Yeah, no, I think I would love it if anybody's interested, if anybody from our hospital or anywhere is interested, just reach out to your rapid response team and just say like, hey, can I shadow you for a day, or just to see what it's like, because frankly we always we'll need some replacements at some point in time, so it's good to know if it's for you and if it's something that you'd want to do. You don't even have to be in the ICU. You could be a floor nurse and trying to figure out what you want to do 5 years from now and be like, all right, like I'm gonna figure it out now, because then you could do the ICU for 5 years and then you're ready if you decide to still do it after that.
Excellent. All right, Michaela, any last thoughts? Any thoughts you want to share? No?
No, nope.
Good.
It
All
was
right.
a pleasure talking to you, and we are happy to have you on our team as our rapid response nurse.
Yeah, Dave, thank you so much for coming on the show and kind of sharing your role with everybody. I'm hoping this kind of just gives people a better idea of exactly what a rapid response nurse is and just how important they are to the entire hospital. So thank you again for coming on. We appreciate it. Thank you, everybody, for listening. As always, any thoughts, recommendations, requests, you can send them to makemesickpod@gmail.com. And you can find us on X or Twitter, whatever you want to call it, at makemesickpod. Dave, thanks again. Everybody, please remember to wash your hands.